Welcome to the webinar, the Mental Health Commission webinar, Life in Recovery, Lessons from the Canadian Centre on Substance Use and Addiction. I'm really pleased that you were able to join us for this webinar. I am Amy LeBlanc and I am Manager of Prevention and Promotion at the Mental Health Commission, and I'm really happy to be hosting this webinar with you today. Before I hand the presentation over to our speakers from the Canadian Centre on Substance Use and Addiction, CCSA, I'd like to quickly cover a couple of housekeeping items and then give you a brief overview of the Mental Health Commission and the work that we do in this area of recovery. So audio is provided in broadcast mode through your computer speakers. You can hear us, but we can't hear you. So if you have any questions or comments, please type and submit them through the question and answer chat box that's on the bottom right-hand side of your screen. Note that the way that we generally approach our webinars is that we hold most of the questions until the end of the presentation, and then I will pose them to the presenters on your behalf and hopefully generate some good discussion. We also wanted to let you know that the webinar is being recorded and that the recording and presentation slides will be posted to the Mental Health Commission of Canada's webinar archive section on our website in the coming weeks. I also wanted to note that at the end of the presentation there's a resources slide with links to most of the documents that will be referenced throughout the presentation. You can download the slide deck right now by selecting Document on the right and clicking the Download Files button. So the next slide is looking at the guidelines for recovery-oriented practice. And these guidelines built on the fact that recovery is central to the Mental Health Commission of Canada's strategy, as well as the calls within that strategy to have specific documents and guidelines related to recovery. And based on that recommendation and the importance of recovery, the Commission was proud to have developed the Guidelines for Recovery-Oriented Practice, which were released in June 2015. These guidelines are about building a common understanding, shared language, and knowledge about recovery, with the hope that it provides a conceptual framework to help transform culture and practice, promote the centrality of supporting people with lived experience and their natural supports or caregivers to play an active leadership role in their personal recovery, as well as to identify the principles, values, knowledge, skills, and behaviors that underlie recovery. And ultimately, the hope was that these guidelines would provide some assistance in implementing a recovery orientation across the sector. The guidelines were developed through extensive consultation, and they seek to really take the concept of recovery and provide a comprehensive review of what it means and how organizations and individuals can practice recovery. So the guidelines break down recovery into sort of 6 overarching themes or sort of principles, and these are to create a culture and language of hope. It recognizes that recovery is personal, but that at the same time that recovery occurs in the context of one's life, that we do not journey alone. It's also important that recovery-oriented practice respond to the diverse needs of everyone living in Canada. And in particular, there's a chapter that looks at working with First Nations, Inuit, and Métis people. And finally, that recovery is about transforming services and systems. So since the release of the guidelines in 2015, the Mental Health Commission of Canada has been working in the area of recovery and working with the sector to really shift, inspire, and mobilize and help move the sector towards a recovery orientation. One of the things that we wanted to do was to build on the concepts that underpin recovery, the ones that the guidelines outline, and really to help translate those into practical actions, skills, and knowledge that practitioners and organizations can explore. So to do this, we've been doing a number of things, including hosting webinars, such as the one that we're on today. And the aim has really been to further explore recovery-oriented topics. We've also been supporting a number of regional events across the country, and so meeting with local communities at the regional as well as provincial levels to really support people's questions about recovery and the shift towards a recovery orientation. So back to our webinar series. So the first 7 webinars in the series looked at each of those specific chapters or dimensions within the recovery guidelines, as well as providing an introduction in detail to the guidelines. Since those 7 webinars and more recently, we've been taking the feedback and comments from the post-webinar evaluations and taking a look at some of the topics that people have expressed that they're interested in learning more about. And so we do our best to try and make sure that these webinars reflect the interests of the audience. And so that's also a bit of a plug to encourage you to fill out the survey and help identify if there's any other topics you might be interested in. So one of the topics that has been suggested by our audience was to discuss recovery in mental health and how that connects with recovery within addictions. And so that leads us to our webinar today and the presentation with the Canadian Centre on Substance Use and Addiction. So I'm very pleased to be introducing our 2 presenters for today. So the first is Robin McQuaid, who is a research and policy analyst at the Canadian Centre on Substance Use and Addiction. She completed her PhD in neuroscience from Carleton University in Ottawa, Canada. And her research has taken a biopsychosocial perspective, examining how biological and psychosocial factors interact to promote or buffer against mental health disorders. Currently, she's examining the effects of trauma and stressful experiences on the co-occurrence of mental health disorders and problematic substance use. As well, I'd like to welcome Kate Musini, who is a National Priority Advisor at the Canadian Centre on Substance Use and Addiction. And she has experience in the field of treatment and recovery from the disease of addiction. So prior to joining CCSA, she worked with the CIHR, Institute of Health Services of Policy Research at McGill University. And she has also completed a bilingual Master's of Public and International Affairs at the University of Ottawa. So welcome to both of you, Robin and Kate, and I will turn the webinar over to you.
Great. Thanks so much for that introduction. It's Robin McQuaid here. I'm going to start the webinar, and then my colleague Kate Musuni will do the last part of the webinar. So I'll just provide a brief outline of what we're going to speak about today. For those of you who aren't familiar with the Canadian Centre on Substance Use and Addiction and our work, we're just going to briefly go over who we are and kind of what we do, and then we'll talk a bit about a national summit that we hosted on addiction recovery, and following that, the commitment to recovery. Today, I think we'll spend a lot of time discussing the findings from the first Canadian Life and Recovery from Addiction survey, and we'll talk a bit about our dissemination toolkit for that, and then Kate will speak to the recovery resource for service providers and decision makers. So just a bit about CCSA for those of you who are unfamiliar with us. We're a not-for-profit organization created through an act of Parliament to provide national leadership to address substance use in Canada. So we are one of Canada's only national agencies dedicated to reducing harms associated with alcohol and other drugs. I think many of you on this webinar today will know that the impact of substance use is significantly affecting our health, public safety, as well as creating a big financial burden in Canada, costing about $40 billion a year. And I just wanted to put up this slide to show some of our national priority areas of action. So these areas are kind of what we focus most of our activities around at CCSA. And today we'll certainly be focusing in on our priority area on treatment and recovery. So with that, I'll jump into talking a bit about the summit that we held. In 2015, CCSA hosted the first National Summit on Addiction Recovery. And this summit really brought together about 50 committed delegates from across the country, and the purpose was really to change the conversation about addiction away from focusing on the problem and towards celebrating the solution. So following this summit, came the national commitment to recovery. And so this commitment really put forth a common vision of recovery as well as overarching principles to guide a strengths-based recovery approach to substance use disorders. And so these principles Kate will be speaking about in detail later when she discusses the recovery resource for service providers. And the commitment also reflected the beginning of trying to come up with a consensus of a definition of what recovery from addiction means. So this is something we'll talk about a bit in terms of our survey results. Following this summit, we developed the National Recovery Advisory Committee, we call them NRAC, to guide the work of CCSA to collectively promote awareness of recovery from the disease of addiction. So they've really helped to disseminate the survey findings and help work closely with us on a number of recovery projects. And this group consists of leaders from across the recovery community who have lived experience and or expertise in recovery research, or some are also clinicians. So a great group that we work closely with and who've been part of these studies we'll talk about today. And so working together with this group, we've really been trying to bring the national commitment of recovery to life and to build our evidence and promote awareness around recovery. And so this has produced 3 recovery products. And we'll be talking about the Life in Recovery survey today, as well as the resource for service providers and decision makers. And then we're also working towards an evidence review, updating kind of the knowledge in recovery in Canada. So I'll begin talking about the Life in Recovery survey. The purpose of this survey was really that in Canada we felt we didn't have a lot of information about the experiences of individuals in recovery. There had been 3 previous Life in Recovery international surveys conducted in the US, the UK, and Australia. And so the purpose of this survey in Canada was really to gain a better understanding about the experiences of individuals in recovery and to find out and better understand the journeys that they have taken and the pathways that exist for them. So the purpose of this survey was that the findings could help inform and educate healthcare service providers, decision makers, and the public about the experiences of individuals in recovery. So I mentioned that we formed the National Recovery Advisory Group to help at a higher level disseminate our findings and work closely on some projects, but specifically to inform the Life in Recovery survey, we formed a Recovery Expert Advisory Group. The members of this group consisted of those with expertise in survey development and research, as well as in the field of addiction and recovery, as well as those individuals who had lived experience. So this group really provided guidance on all aspects of the Life in Recovery project, from the development of the questionnaire to kind of the interpretation of the study results. So I'll speak a bit about the survey methodology. This was an online bilingual survey conducted similarly to the US, UK, and Australia. So we formulated our questions based on those previous surveys, but modified them to reflect the Canadian context. And we also added in some additional questions to this survey, specifically focusing on the barriers to initiating and sustaining recovery. This survey was out in the field from April 18th to June 1st, 2016. And we used a non-probability snowball sampling technique to recruit our respondents. So what that means is we shared the survey link with our networks and stakeholders, and they shared the survey link with their networks and so on. And we largely did descriptive analyses in the report that we'll be showing today. I did want to provide a location breakdown, so this is showing where our participants participated from. We did have almost about half of our sample, 45.7%, who lived in British Columbia, so it was a bit of a geographic sampling bias there. We had 25.5% in Ontario and 10.5% in Alberta. 8.9% were in Saskatchewan, and then lower numbers, 2.7% in Manitoba and 2.1% in Quebec. In the remaining maritime provinces and in Yukon and Northwest Territories, we had just a little over 1% or less than 1% who participated in these regions. So I also wanted to give a breakdown of our survey participants so you have a good understanding as to who participated in the survey. We had 855 respondents overall with a mean age of 47 years. About 53% were female, 45.7% male, and 1.2% identified their gender as other. We had just about 80% who reported their ethnic background as white or European, and 9.8% who self-identified simply as Canadian, 8.4% who self-identified as Indigenous. And we had a fairly educated sample, so 62.4% had completed college, university, or a higher level of education. and almost 80% of the sample were employed. 50% were in a relationship, either legally married or common law, and 61.4% of our sample had children. So it's important just to understand when we look at the data who this data is representing, and so we're providing the breakdown of the participants for that reason. I wanted to start off the results section by giving a quote. So this is from one of the participants in the survey that says, "Recovery gives me freedom, it gives me choice. It allows me to follow my dreams. I'm no longer chained to my addiction." So we had a number of participants who reported having a good quality of life. So about 90.7% of participants reported the quality of life as good, very good, or excellent. We also examined, in addition to quality of life, mental health symptoms, and 84.2% rated their mental health as good, very good, or excellent. So again, high self-reported ratings of mental health. In addition to self-reported ratings of how they were feeling, we asked them whether they had ever been diagnosed with any sort of mental health disorders, and we found that 44.7% reported that they had received a diagnosis for a mood disorder at some point in their lives. In addition to mental health, we examined physical health and found that 80.8% of participants reported their physical health as good or better. So again, reporting quite a high level of physical health. 50.2% of participants had been diagnosed with a physical health issue. So we'd asked that same question, whether they had ever received a diagnosis for a physical health issue. And the most common physical health issues were cardiovascular disease and gastrointestinal diseases. So we asked them some questions about the age when they first used substances and found that respondents' median age of first drug use was 13 years old, and their median age of addiction was 18 years old. It's quite a young age there. We also asked questions about the specific substances they used and found that the most common drug they first used was overwhelmingly alcohol at 64.2%. So in addition to the first substance use, we asked them questions about the substances they used both during active addiction and what their drug of choice was. The top 5 most prevalent drugs used during active addiction were alcohol at 93.3%, followed by tobacco at 81.8% and cannabis at 61.5%. This was followed by cocaine or crack and then hallucinogens. So I've just shown the top most common substances, but certainly in the report we have the range of all the complete responses by participants. When we looked at the top drugs of choice, again we found that alcohol was the most common drug of choice at 50.5%, followed by cocaine at 18.8% and cannabis at 7.7%. Heroin and street opioids were 7.1% of the participants' drug of choice, and 5.5% reported prescription opioids. So from this picture, we're certainly understanding that alcohol is a significant burden of society, being the most common drug first used, most prevalent drug used, and one of the top drugs of choice. So we know that there are many definitions of recovery from addiction, and we certainly know that this can be somewhat a contentious issue where it's hard to kind of all agree on one definition. So what we did in the survey was ask participants in an open-ended question for their own definitions of recovery, and we coded these qualitative responses into themes. And so what you're seeing in this table is really the themes and concepts that we coded that were the most common. So certainly there were a broad number of ways that individuals defined recovery. Over 25 different themes were coded in this answer. And so I've shown again the top responses here. And we see that abstinence is the most common at 52.4% of the definitions. But certainly participants described and defined recovery in many different ways, and that could include having a good quality of life or using an addiction program. Some participants included conversations or discussions about spirituality in their definitions, and emotional health and physical health. Participants, 7.4% suggested that thoughts about cravings or drugs were part of their definition, the absence of those. And a number of people reported being a productive and functional member of society was part of their definition. So in addition to asking participants to kind of give us their own definitions of recovery and how they understand it, we also posed a question to all participants. We asked the following question. So although there's no standard definition of recovery from addiction, many definitions include changes in lifestyle and behaviors to address the biological, social, and spiritual troubles because of addiction. In addition to abstinence or stopping uncontrolled substance use, recovery implies improved health, function, and quality of life. Does this reflect your understanding of recovery? And 96.3% agreed yes, answered yes, that this is part of their definition of recovery. This is the way they can explain recovery. 3.5% answered no. So we were very curious to know more about the factors that are involved in individuals starting and maintaining recovery from addiction. And so we found that quality of life reasons, mental health or emotional reasons, marital and family relationship reasons, and physical health reasons were the top 4 most common factors in both starting recovery as well as in maintaining recovery. But certainly you can see in this table that there are other factors that participants thought were also important for starting and maintaining recovery as well. Now I mentioned that the Canadian survey was the first to examine barriers to both starting and maintaining recovery. And so what we found was that 82.5% of participants reported that they experienced 1 or more barriers to starting or initiating recovery. So you can see the top responses in this table. The most common barrier participants reported was not being ready or not believing they had a problem, or just that the problem was serious enough. So that was reported by about 55% of participants. Just about 50% of participants reported being worried about what others would think of you as a barrier, so really showing the impact of stigma there. And about 35% of participants did not know where to go for help. So we also noticed a number of barriers relating to access to care. So these included long delays for treatment, a lack of professional help for mental health or emotional problems, the cost of recovery services, and really a lack of programs or of quality programs in their communities. We also asked about barriers to maintaining recovery, and there were fewer. So 54.2% of respondents did not experience barriers to staying in recovery. So just slightly under half would also still report barriers to staying in or maintaining recovery. Now, when examining relapse, we found that just about half of participants did not relapse. And you can see in this table of the other participants who reported relapsing, we're showing the number of relapses that they reported. So we can see that about 14.3% reported relapsing once. About 20% of the sample reported relapsing between 2 and 5 times. And about 6 or more about 15% of the sample reported relapsing between 6 or more times. So these data kind of go to show us that recovery is an ongoing process for many, and it also really speaks to the fact that recovery is such a unique and individual experience because someone who has relapsed one time, their experience of recovery would be quite different than individuals who have relapsed multiple times. So we know that the view in the recovery literature is that there are multiple pathways leading to recovery. And our findings from the survey certainly supported this. Participants on average use between 6 and 17 different services or supports during their recovery journey. So the most common of those I've shown in this table, but about 91.8% reported using 12-step mutual support groups, and 60.6% reported using a residential addiction treatment program. Just about 60% or less, so just under 60% reported using just 1 second here, using a group or individual counseling by a psychologist or a non-psychologist. And we had 41% using outpatient addiction programs, and 35% using detox programs. So there is, again, just a number of different recovery resources and programs that participants reported using, really showing just how different people's recovery experiences were and how many resources and programs they drew on. So in addition to recovery resources and programs, we also looked at a number of informal supports that participants used. And what we found was that participants, again, drew on a wide range of recovery supports. The most common recovery support was using relationships with friends or family. So just about everyone, 96.8% reported using relationships with friends, and 95.4% relationships with their families to help support recovery. But you'll also see that participants drew on a number of other supports such as religion. Some reported meditation and recovery reading and exercise. A number of participants reported using relationships with animals, pets, and with the land. So again, I've shown the top responses, but in the report you certainly see the full range of responses here. So in the next few slides, what I've done is just, we asked participants about their experiences during both active addiction and recovery. And so we're comparing these responses here on a number of different areas, such as family and social life, their health, work and study, legal issues, and finances. And so as you can see in this graph here, on the far left of the graph, we're looking at regularly participating in family activities. And so we see that participants in recovery reported 93% of them regularly participating in family activities, whereas only 31.0% of those in active addiction reported experiencing this. When we look at the far right of this graph, we can see that when we look at family violence, 4.9% of those in recovery reported family violence, whereas 41.2% of those in active addiction reported family violence. So next we looked at health experiences during active addiction and during recovery, and found that when we look at the far left, participants experienced fewer untreated emotional or mental health problems when in recovery. So 12.7% reported experiencing untreated emotional or mental health problems in recovery, where 74% of participants reported this during active addiction. We also see that when looking at frequently attending emergency departments, 1.2% of those in recovery reported this, but 25.3% of those in active addiction reported this. We didn't really see many differences in terms of using healthcare services other than emergency departments. But when looking at a family doctor, more individuals in recovery, so 90.2% of those in recovery reported experiencing having a family doctor, whereas 70.8% reported this in active addiction. And in terms of visiting a doctor when they had a health issue, it was more common in recovery, so 96.3% in recovery and 63.6% of those in active addiction. So moving on to work and study. In terms of work and study, we found when you look at the graphs right across the board, that about those in recovery were experiencing many more positive experiences during their work and study. So we see that participants in recovery were more likely to remain steadily employed compared to those in active addiction. They were more likely to get good job performance or evaluations when in recovery, more likely to further their education or training compared to active addiction, and more likely to start their own business as well. So the last domain we examined was legal issues, and we found that when examining legal issues, again, right across all of the questions that we asked, participants were much less likely to have legal issues during recovery compared to active addiction. So this was true of damaging property or getting arrested, having criminal charges laid, completing probation, or parole, and serving jail or prison time. So essentially, when we looked at these findings of the comparisons between recovery, and active addiction, we found that across all the domains, individuals in recovery had many more positive experiences and fewer negative experiences than during active addiction. We also noticed that these findings were really mapping on quite well to the other findings from the life and recovery surveys done internationally. And so in the report, we actually compare these percentages to the other reports and show how similar many of our findings are across the 4 countries who have done life and recovery surveys. So we also wanted to know about their experiences of stigma and discrimination, and found that 48.7% of participants reported perceiving stigma or discrimination during their active addiction. The most common theme we coded was being judged, looked down on, or harassed or ridiculed by others. So one participant stated, "I was constantly treated as a second-class person." 33.2% reported such perceptions during recovery. So the most common theme during recovery was perceiving persistent judgmental attitudes and negative views about addiction and individuals with addiction. So one participant stated that people assume once an addict, always an addict. Now, the final question of the survey we left completely open-ended, and we asked participants if there's anything they wanted to share that they haven't already, or anything that they wanted to express to us in that open-ended question. And so what we found was that individuals, some took the time to really discuss the negative effects on their lives that took place during active addiction. Some individuals focused on their poor mental health or suicidal ideation they experienced during active addiction, but others took the time to focus on some of the positive events and changes in their lives since starting their recovery journey. So we're just highlighting the most common theme during recovery that we identified in this question was really the formation or repair of meaningful relationships. So one participant stated, "I gained custody of my daughter back. I've had family and family friends tell me how proud they are of me and what a great mother I am." The second most common theme in this question when looking at recovery was improvements in their mental health. So one participant said, "I've been able to get a better understanding of my mental health. It's an ongoing journey, but it's better than it was." So we've coded many more and provided many more quotes in the survey, but I've just pulled a couple to reflect those questions. So just before I conclude, I wanted to acknowledge some of the data limitations in this survey. This is a self-select non-random sample, so therefore we can't really infer that the findings of this specific sample who chose to participate can be extrapolated or inferred to the larger Canadian population. It's also true that this sample was heavily BC-based, so we had about half our sample in BC, and so that's likely due to the snowball sampling technique we used to obtain the sample. And the survey was offered only online, so there could be a chance that participants could not participate or did not have access to online. And so again, this could impact our participation. So for example, we had a largely white, highly educated sample. So we can't exclude the possibility that this could be due to the online survey. And then just in terms of self-report studies, as with any study that is self-report, we have to be careful of self-report bias, that participants might have been more likely to want to report positive findings during recovery and more negative during active addiction. But despite these limitations, this survey really provides us a wealth of information that we just hadn't had access to before. We now know that individuals use on average 6 of 17 different recovery programs and resources during their recovery journey. We also know that they experience a number of barriers specifically related to accessing treatment, such as long delays for treatment, the cost of recovery services. And it's also concerning that some participants reported not knowing where to go to seek help. So the results from the survey can really help demonstrate the system-related issues, and the findings can help inform healthcare providers, policymakers, and decision-makers really about the programs and supports that help facilitate recovery, but also about the barriers that are standing in the way. And the intent of the surveys also to increase understanding with the aim to address stigma associated with addiction and recovery, so increasing understanding that individuals in recovery lead meaningful lives and contribute to society in meaningful ways. The data highlight above all that life in recovery and recovery is possible, and for many includes a positive quality of life even when addiction was marked by high severity, complexity, and chronicity. And the findings, we really feel offer hope to individuals and families and communities that are affected by addiction, by the professionals seeking to assist them, and they help inform policymakers about the value of providing funding for treatment and recovery resources in this population. So following the survey, we're working currently on a couple future directions with this data. So this data set really gave us such a rich data source that we've only really scratched the surface of exploring in the report, where we provide frequency type data. We're now doing more in-depth analyses looking at the differences according to various subgroups. So we've started to look at gender and whether there are pathways between individuals who report it being male, female, or other. And we're also looking at barriers more in depth to determine whether there are certain barriers that are really impacting recovery outcomes, such as relapse. So before I move this over to Kate, I'll just mention that we have a communications toolkit on our website, and I believe this is also a link that we're sharing at the back of this deck with you. But it's really a communications toolkit for any organization or stakeholder who wants to help share the findings of the Life and Recovery Report. So included, you can see a social media page, but we have infographics, website graphics, and social media images and key messages that are available just to download and share. So with that, I'm going to turn it over to Kate, who's going to speak about the recovery resource for service providers and decision makers.
So thanks so much, Robin. So as you mentioned, I'll be discussing today the Moving Toward a Recovery-Oriented System of Care resource for service providers and decision makers. This resource was recently launched in September in conjunction with Addiction Recovery Month and is targeted towards service providers and decision makers working in the substance use and addictions treatment system. The purpose of the resource is to increase knowledge about recovery and show the value of adopting a recovery-focused approach, as well as to provide actionable examples of policies and practices that support recovery, as well as the recovery principles. This resource builds on the collective vision and 6 guiding principles in the National Commitment to Recovery from Addiction in Canada. In fact, it provides the organizing framework for this resource. For each recovery principle, the resource describes what it means for the system of care and why it is important for the system, individuals, and families. We also included findings from the Life and Recovery Survey to show how the experiences and journeys of people in recovery illustrate the relevance of each recovery principle. Finally, for each principle of recovery, the resource presents a list of policies and practices that can be implemented to support the principle. We'll briefly go through each of these 6 principles now, and I'll share a few examples of what each principle looks like in action. The examples in the resource were generated from consultations with 41 stakeholders in Toronto, Vancouver, and St. John's, Newfoundland. These consultations included service providers, addiction medicine doctors and nurses, leadership from workforce certification and recovery facilities, as well as researchers. Of course, 3 consultations does not capture the diversity of experiences and perspectives in the recovery community. However, this was meant to be a living document that can be updated with further data as we move forward. So the first principle is that there are many pathways in recovery. Addiction is complex, and how it develops and progresses is determined by the interaction of biological, social, and environmental factors that differ across individuals. The pathway to recovery may involve different combinations of treatment options, different community and informal supports, and relapse can occur for some. To support these multiple pathways, we need to tailor treatment and recovery programs to individuals and offer them a range of options. Examples of how this principle can be incorporated into daily practice include educating clients and their families on the availability and validity of multiple pathways to recovery, offering clients a wide range of services during treatment, and connecting clients to the broad range of addiction recovery supports in the community, and introducing or involving these supports while the individual is in treatment. The second principle is that recovery requires collaboration. This extends to service providers and community support systems, as well as between professionals across health and social service sectors. Cross-sectoral collaboration is especially important for prevention, early intervention, and treatment. Given the complex nature of substance use and the related problems that are concurrent or emerge with addiction, individuals may enter the system at different points and also require services from other sectors, including housing, employment, primary care, hospitals, criminal justice, and schools. Similarly, community-based supports and services are important for recovery outcomes, and these supports are ideally accessed during active treatment and can provide continuity of support when clients continue with these supports after treatment. Examples for implementing this principle include educating all staff on the importance of interprofessional collaboration and creating opportunities for staff to engage in knowledge exchange activities, meeting regularly with community services such as mental health and addiction support services, mutual aid groups, etc., to collaborate on initiatives to address the full needs of clients served, and creating a roadmap for staff highlighting the various programs and services in the community so that they can support clients during transition periods. Similar to the idea of there being many pathways in recovery, the third principle reflects the idea that recovery is unique to an individual and changes as the individual changes. The right type and combination of services and supports should be guided by a comprehensive assessment and is ideally tailored to the individual's needs, preferences, culture, and strengths. Examples for how this principle looks in practice include implementing a trauma-informed approach throughout services and programs, offering childcare services on site or making arrangements with daycare programs for parents with young children, and engaging diverse stakeholders, including those with lived experience, when designing and evaluating programs and services. Principle 4 introduces the concept of recovery capital by noting the ways in which recovery extends beyond the individual. The recovery process also includes the individual's family, friends, workplace, and community. The recovery capital concept has been increasingly shared across the addiction recovery community. It speaks to the idea that the majority of a person's journey in recovery occurs outside the boundaries of mental health or other services. Social networks and relationships provide important support in recovery. These relationships are part of what is referred to as recovery capital, which is defined as the personal, interpersonal, and community resources that a person can draw on to begin and sustain recovery. This can include health, finances, values, knowledge and skills, family and friends, connections to school, work, religion, and addiction treatment and recovery supports. In fact, the Life in Recovery Survey reflects this idea in its findings. Over 95% of participants relied on relationships with families and friends for support in their recovery. Marital, family, and other relationships were among the top reasons participants began their journey of recovery, which is reported by 64.9% of participants. And over 2/3 of participants who relied on relationships with families and friends as supports rated them as very important to their recovery. So examples for incorporating the recovery capital concept into practice include including the quality and quantity of a person's recovery capital in the assessment process, identifying online, telephone, or other supports for clients living in remote locations and for those seeking long-term support, and providing opportunities for persons in recovery to build friendships with others by organizing or connecting them to social activities, including hosting dinners, dances, sport tournaments, and other community events. Principle 5 shows us that recovery is multidimensional. Recovery involves addressing the multiple dimensions of a person's health, including physical, social, mental, emotional, and spiritual health, and services must be coordinated to reflect this. Recovery is not only addressing problematic substance use, but also other dimensions of health that are often impacted by addiction. This also highlights the importance of collaboration, where you may partner with other services or community or associations to provide access to a wide variety of physical, cultural, artistic, social, and skill development activities. Examples for implementing this principle include including programming or resources on eating well, exercise, sleep, mental wellness, and involvement in social activities, creating a welcoming, open environment where individuals are encouraged to practice their cultural, spiritual, or religious customs, and providing information in classes on meditation to emphasize the importance of positive thought and mindfulness. Finally, Principle 6, recovery involves everyone. We all have a role to play in overcoming the stigma of addiction and recovery and contributing to a society that is compassionate, understanding, and supportive. Part of overcoming stigma is changing the language and conversations around substance use, addiction, and recovery. We need to shift the focus from the problem towards the solution. The key message to share is that recovery is possible, achievable, and sustainable. We also need to dispel common myths that being dependent on substances is not a choice or a moral failing, and promoting the idea that addiction is a complex and chronic health condition with many risk factors. Examples for reflecting this principle in practice include co-developing or co-delivering with people in the recovery community, education campaigns for the public, and targeted presentations for key stakeholders, and providing outreach activities such as workshops, information booths, or talks at diverse locations in the community to increase awareness about addiction and recovery, treatment services, and recovery support services. When we envision the implementation of the recovery principles as brought to life by the examples in this resource, we begin to form a picture of what a recovery-oriented system in care of Canada might look like. However, from the consultations, we heard that the national commitment is more of a goal than a reality. To move towards an ROSC, we need greater collaboration between service providers, more coordinated community-based services and protocols, measures of long-term recovery outcomes, shared language, and we need to work together to continue to reduce stigma. In this toolkit, we discuss examples for system-level changes to move towards a recovery-oriented system of care. Some of these include developing standardized measurement tools and mechanisms for assessing long-term recovery outcomes, engaging persons with lived experience on all aspects of program design, development, implementation, and evaluation, and creating opportunities for collaboration across sectors to address the economic and socio-cultural risk factors that contribute to the development and progression of harmful substance use and addiction. As I've said, this resource is meant to be a living document, so we encourage participation from our audiences to help it grow. So please share examples of recovery-focused practices, policies, or tools with us. You can reach us at recovery@ccsa.ca and share with us your stories of how you've used this resource in your daily work. So to bring this session to an end, we just wanted to remind everyone that CCSA is hosting our biannual conference. This year it'll be in Calgary. It's a really unique opportunity to engage with a large variety of addiction workers, healthcare professionals, researchers, policymakers, and knowledge brokers from across the country. Provides an opportunity to share new developments and best practices, and offers practical training related to prevention, treatment, and recovery. And we encourage everyone to attend. So Robin and I are happy to take questions at this time.
Great. It's Amy here at the Commission. Thank you so much to both you, Robin and Kate, for your presentation. And as Kate mentioned, we do have some time. So if people who are on the webinar have any questions, if you wanted to type it in as a question, then we can pose them for you. So a couple have come in while you were both presenting, and I think one question you ended up answering, Robin, as you listed some of the limitations of the survey, but someone had asked about it's currently the survey was only available online. If you do the survey again, do you have any plans to offer it in any other ways other than online, just to access people who perhaps don't have computers or access to computers?
Yeah, it's a great point to bring up, and we do acknowledge certainly it's part of the limitations with any online survey, that we have to be careful to say, who these results are made up of, and be careful not to extrapolate to people who maybe did not have access to online computers. But I'm not sure about our plans to redo the survey, but certainly it's something that we want to keep in mind and keep on our minds if we're going to repeat surveys like this in the future.
Has there been any conversation or is there any possibility that Stats Canada could include questions about recovery in the Canadian Community Health Survey?
Not to my knowledge. I'm not sure. I know just from what I've heard, I think there's limited space in that survey, and so I know getting questions in can be difficult, but not to my knowledge, and I'm just looking at Kate to see if she's heard anything as well.
No, I haven't, unfortunately.
And then one of the other questions, and this may not, again, if you're not sure about plans to redo the survey, but is there a possibility to include questions such as what would people want to access in terms of recovery-oriented services? That's
a really great question, and I think that's something we've been talking about too here. Now that we've we understand there are a lot of barriers. We understand that some people are not able to access treatment, and that, we're kind of just having discussions on our end about, what is needed, what could be the facilitators, or what services kind of are needed and are not there. Certainly in the survey, some of the qualitative data that came through spoke a bit about, there needing to be more treatment options and more options for, in particular, youth was a topic that came up quite a bit. But yeah, I mean, it's something that we're discussing. It would be great to have some more specific information about what exactly, what services exactly participants would like that they don't have access to currently.
That's great, thanks. There was a question about how did individuals find out about the survey?
Yeah, so that, I'll say a bit, and then maybe Kate can help me out as well. So that was something like we shared the link as widely as we could to participate. We shared it with, we have a large network and a large group of stakeholders that we shared it with. And we also, we posted on our website, and we reached out to some addiction treatment facilities and recovery groups to see as well if they could help disseminate and share. So it was really that snowball effect where we started and reached out as widely as we could, as well through social media posts as well. And then it got shared from there. And at that point, we don't really have control over who chooses to continue to share the link with their friends or networks or other addiction facilities or not. But that's how it was done. And, would have been ideal to be able to do a random sample where we knew exactly how many individuals in Canada are in recovery and have a list and sample from that way, but certainly that's just not an option. So this was what we felt would be the best way to kind of try and recruit. And actually, we did not think we would get as many participants as we thought. We, I think, had hoped for about 500, and we had 855, so we were pretty pleased with that.
One thing I'll add to that is partnering with the National Recovery Advisory Committee was really critical, and especially with this survey, to expanding the reach of the survey. So, these are individuals representing recovery community from across Canada. So we really relied on them to disseminate the survey several times throughout their networks, to promote it at events that they were attending related to recovery, and so on. And as Robin mentioned, we were really pleased with the outcome in terms of the number of participants that actually completed the survey.
Great, thank you. And the survey provided you with some good information on what the survey respondents, kind of what they thought about recovery or how they defined recovery. Is CCSA incorporating that information in their own definition of recovery?
So there was kind of two ways we looked at the recovery definition in the survey. One was just an open-ended question, and we asked them for, their own definitions. And I would say a lot of what we heard in there is reflected in common recovery definitions. So good quality of life, being a productive, functional member of society, those are really key to many definitions of recovery addiction. And then we also provided a definition where we actually modified a definition from ASAM, the Addiction Society, American Society of Addiction Medicine, sorry. So the definition we gave where we posed that question about, there being no standard definition, but here's how we understand it, that was actually a kind of a well-known definition, and we slightly modified it to pose that question. So yeah, we're certainly reflecting those kind of broader concepts of recovery definitions in the survey.
And going forward, for example, in the resource, we do cite the definition that was informed by the survey results in our products. So yeah, we are using that going forward.
Great. We had a comment that also goes into a question, and that is that one of the webinar audience members found the stats on relapses very interesting. And they go on to ask, the trans theoretical model seems to imply that relapse is inevitable, but this doesn't seem to be true for about half of the respondents.
Yeah, I mean, certainly we can only speak to what we saw in our survey. It was about 50% who did not relapse. And again, then there were others who had relapsed many, many times. And so I think we just need to also keep in mind that this, this is a self-reported survey, and this is also a survey of people who chose to participate, and we can't, ignore the fact that perhaps those people are doing really well who wanted to participate and share their findings. So certainly all we can say is that in this sample, that was our finding, but that doesn't necessarily mean that that would kind of be consistent for Canada in any way. I hope that answered your question.
That's great, thanks. We've also had a question, if the CCSA site has a list of community resources that would be available, or a list of services and supports that could be provided to clients, or where people might be able to access that?
I think we are working to develop a guide for individuals looking to find services, and I think that's something that's being developed in partnership with the Canadian Executive Council on Addictions. So I'm not sure of the exact launch date, but I believe it is this fiscal year. So certainly, we noticed the gap and are looking to fill that gap by providing resources for individuals to find the resources and the treatment options that they're looking for.
And then we have a question about peer support. And so with almost 92% of respondents indicating that they use peer support, why was there no further mention of peer support in your report or referring clients to peer support groups?
So I think, in this survey, it's really a first look at the experiences of individuals, what supports did they use, what programs did they use, and we weren't able to, with the limited amount of, the survey is already quite long, as I'm sure you see with all the results here. We didn't dive into any one of those specific kind of peer supports or any of the responses. It was really to get a good idea what are people using during their recovery journeys, but not really to look at one or others in depth. But got to better understand what are people using in recovery as kind of a first step.
And we do highlight in the resources that I covered the role of engaging with peer support and individuals with lived experience, because we do understand that to be a very important part of many individuals' recovery journey.
Thank you. So I know we're coming up on the 2 o'clock time, but we've been continuing to get a number of questions in. So I think what I might do is pose maybe another question or two, and then we can close out the webinar. So one of the questions that we have, and we've gotten a couple of questions related to this, and that's about how harm reduction fits within some of this recovery work within the survey. And certainly, there's been some comments that harm reduction fits within some of the mental health, kind of the mental health definitions of recovery around self-determination and choice. So curious if or how you see harm reduction kind of weaving into some of the work that you've done.
Certainly. So as many of the webinar participants might be aware, this is an issue for specifically the addiction recovery community. But especially from the beginning, outlined in the National Commitment to Recovery, the role and the important role of harm reduction as a pathway to recovery was certainly highlighted and acknowledged. And I believe also in the survey findings that we found that harm reduction services were also used by participants as well. So certainly there is a value, and we don't want to speak necessarily for the recovery community in terms of there are individuals that prefer a harm reduction approach over an abstinence-focused approach, but I think the gap within the community is starting to close in terms of understanding the importance and the value of of harm reduction services as one component of the pathway that may lead to recovery.
Yeah, and in the survey results, this was in some of the qualitative findings, we were asking them about the programs or resources, and a few people did take the time to really talk about the importance of harm reduction and increasing harm reduction services. So certainly something that's very important.
Great, thank you very much. I think since we're rapidly coming up on 2 o'clock, we will close out the webinar. So I really want to thank both Robin and Kate for taking the time to come and talk to us about your work related to recovery in the addiction sector. I suspect that these conversations will continue and be ongoing as we work more and more closely between mental health and addictions, and as lots of us are working through language that continues to evolve and grow and change. So really appreciate you both being here. We have a slide up with some of the links to resources, and we thank all of you for joining us at the webinar, today's webinar. When you close out your webinar, you'll get an email with a link to a survey, so we do ask you to fill that out and let us know if there's other topics that you might be interested in. And thank you again to Robin and Kate and to all of you for joining us.
Thanks for having us.
It's a pleasure. Thank you.